Hello, and welcome to Voices in Leadership from the Harvard T.H. School of Public Health. I'm Eric Anderson, the director of this program, and it is my pleasure to welcome you today for another exciting installment. Our goal with Voices in Leadership is to focus on effective leadership to create positive change in public health. Today, we welcome Dr. John Whyte, Chief Medical Officer of WebMD and Medscape. Dr. Whyte is a physician and corporate executive. His unique combination of government and private sector work provides him with an exceptional perspective on wellness, clinical trials, information technology innovation, and healthcare services. Prior to WebMD, Dr. Whyte served as the Director of Professional Affairs and Stakeholder Engagement at the Center for Drugs Evaluation and Research at the U.S. Food and Drug Administration. Before his public service, Dr. Whyte worked for nearly a decade as the Chief Medical Expert and Vice President of Health and Medical Education at Discovery Channel. In our program today, Dr. Whyte will discuss his path to leadership, how he has worked at WebMD to provide trustworthy information related to COVID-19 for its consumers, and the importance of science-based communications, among other subjects. He will be joined in conversation with Professor Barry Bloom, the Joan L. and Julius H. Jacobson Research Professor of Public Health and the former Dean of the Harvard T.H. School of Public Health. Professor Bloom, I turn this discussion over to you. Thank you.
Thank you so much, Eric and John. It is a great pleasure to welcome you back to, virtually at least, to the Harvard T.H. Chan School of Public Health. You've had a truly extraordinary professional journey, trained as a physician, receiving a master's degree in public health and being an alumni of our school, serving in the government at the FDA, moving to the private sector at the Discovery Channel, and now Chief Medical Officer of the most important source of health information for the public. How did those experiences inform the decisions you've made, and how did they shape your career?
Well, Eric and Barry, I want to thank you both for inviting me. I wish I could have joined everyone in person, but you know, we're in unique times. As you mentioned, I've had this opportunity to be in and out of government. And I have to say, my education at Harvard, at the T.H. Chan School of Public Health, really was decisive in teaching me these critical skills to think about populations. You know, as physicians, we're really taught to train and treat that person in front of me and not really worry about the rest of society. And in public health, the perspective is a little bit different. And also, my time at the school taught me about the global community and how we really have to address the needs of the entire world. And we're learning it during COVID, that we're not safe unless we're all safe. So it really has shaped my thinking. And in many ways, I think it has made me better in each job. So in my roles in government at Medicare and FDA, you know, I'd say to them, Barry, well, this isn't the way it really works as a physician, because I've always have seen patients. So nowadays, I only see patients about once a week. And I'll be honest, it is a scheduling issue because I have a day job and I've had different day jobs for the past, 20 years. But it's important because at the end of the day, that's what my role focuses on, that physician-patient relationship, the health of patients. So it really has given me a good perspective, because in many ways, when you're either in the public sector or the private sector, you just have that mode of thinking. But when you've been back and forth in the different environments, I think it helps you to think through, how are we going to make this happen? How do we create good policy? So it's been a balancing act at times, but it's one that I think has made my professional career and my personal life much more interesting.
Perhaps you could comment on the two areas in which you have made enormous contributions. One is the educational role, and the other is the policy role. Do you see them as being divergent or in tension, or are you trying to put them together and move forward, moving policy into the more general of health in the more general population?
Absolutely. I think they're very connected. And I joked with you previously, people always see me as almost like a communications or a media expert, but I really view myself as a policy person. And I've always said I want to do health policy. And I joke with students and young physicians now who tell me they want to do health policy. And I go, oh, what does that mean? I don't know what that means. Although I do know, because the point is, at the end of the day, it's all about how policy is impacting health, whether it's your personal health or public health. When I was at HHS, we used to talk about translating research into practice. And that's what it's really all about. So in many ways, I want to educate folks, whether it's that patient in front of me or populations, about a disease state, about policies that impact their care, as well as physicians. And that can be a challenge because there's lots of competing interests. So all too often, Barry, everything's so insular. The policy people are over here. The research people are over here. I mean, you know that it can be like that at the school at times, and the clinicians are over here. But we all have the same goal, but we often don't communicate enough and reach out. We're used to just hanging out with our own folks. And in many ways, we have to mix and match sometimes, and that can be hard to do.
That's also true of the practice of medicine,
Yeah.
in the sense that much of public health is a public sector government responsibility in the federal and the state governments. And yet the practice of medicine in the United States is largely private. How do you see those sectors interacting in the same way you see policy and education interacting?
I think it's hard, and I'm going to be honest. Sometimes I think there's a snobbery against other professions. So, sometimes when you're in the federal sector, as I've been in, and people say, oh, you think that's difficult? Be glad you're not in state government. And then, in state government, they'll focus on federal and be like, well, those folks never get anything done. So in many ways, there's almost automatically this bias against people that are in a different, career profession than you. But it's really about, it kind of sounds cliche, reaching across the aisle. But if we really want to have meaningful change, get results, we have to work with people that have different perspectives than we do, that have different skill sets than we do. And that's what I've tried to focus on in my different careers. And sometimes people will, question your motivation. Why do you want to do this? Or stick with the physicians, or stick with the policy people. And it's really about, in many ways, breaking down those walls that separate all of us, that keep us in these silos. I mean, that's what we need to do if we really want to solve crises and have an impact.
So you're having impact by being the leader in the #1 source of medical information for the public in the United States of America. Tell us something about your vision for WebMD, why you chose to go there in the first place, and what the vision was, how far you think you've gone in that vision, and something about what you think its impact is.
Yeah. Well, that's a lot to cover. I'm doing my best. And I'll start off with saying, because people always, like ask me, well, how did you get into these roles? And, I didn't go to college thinking that I was going to work at, global media companies or in government. I thought I would be a surgeon. I always wanted to be a doctor. I remember that. I was like, I'm going to be a surgeon. And then I did surgery and I decided, I don't really like that, because I was interested in policy issues and in populations. I thought, well, I can't do that being in the OR 10 hours a day. And then I thought, Barry, I'd be a dean. I'd be a chair of medicine. And that was kind of my career path. Went to Duke for residency, and everyone does a fellowship, and then I went to Stanford. Uh, but then I realized if you want to impact policy and populations, there's a role for government. So I always have had this perspective of I want to impact populations. And one of the ways to do that is communication. But again, back to this idea that, I'm really a policy person, but I'm using communication strategies to impact policy. So at WebMD, we really have this idea and perspective that better information is going to create better health. And we like to say, all of us, that knowledge is power, right? So we want to make people powerful, but we want to give them the right information. And how do we help them get that best information? And we're learning it now. There's a lot of misinformation out there. And COVID pandemic really has made people start to take more control of their care by doing more at home, by using apps, what I call almost this DIY approach in medicine. It's do it yourself in terms of managing your care. So our goal really is to provide the best health information to people, to empower them to help make decisions about their personal health. And that's often in consultation with their doctor. So a lot of people will be like, oh, I go to WebMD and WebMD tells me this through symptom checker. Well, we clearly say, on our tools and our apps that these are not to diagnose conditions, but these are to help you have a more productive conversation with your doctor or other health professional. But Barry, we've also learned that we need to effectively communicate through different strategies. So what I've been very interested in is it's not just text, it's also the power of video, because we know now more than ever, that's how people consume information. It's about the importance of graphics and images. What I learned at Discovery Channel, which is often hard for physicians and academicians to recognize, is the power of storytelling. It's not the power of anecdote per se, in the sense of an N of one, but it's about telling the compelling story that incorporates what the typical patient might be, or to use the power of storytelling to bring someone in so I can then give them more information. In many ways, people think if you build a website, people will come, or if you have a blog, people will read it. Well, we shouldn't assume that. There's a lot of competition out there. So how do we provide the people the best information? And I think in many ways, what I'm proud of my colleagues are that we're continuing to iterate. We're continuing to say, let's study our audience. Let's understand what are their needs, what are their preferences for information. Let's talk about that patient journey. Nearly 80 million people come to WebMD every month, and they search multiple pages, spend over 6 minutes of time. That's a lot of eyeballs, and they're coming back, and we want them to come back to get better information, to use that information to help make decisions. Because if you remember, even 5 years ago, people would print up what they read online, right, and they'd hand it to us, and what would we do? We really wouldn't do anything. We just continue to do what we're doing. Now, people search back pain, knee pain online. They want to talk to an orthopedist or rheumatologist today, and they can do that through telehealth. Or they want to get a X-ray appointment tomorrow. So how do we help them connect that content to care? So I'm very excited about what we're doing at WebMD and Medscape, because we're really trying to be a leader in providing that best information to consumers to help improve their health, and do it in a way that really responds to what their needs are.
We are similarly trying to be a leader in academics in public health. And if you'll forgive me, I would say that since you were a student at the School of Public Health, during my reign of terror as dean, I proposed a change in the mission statement for the Harvard School of Public Health, which was to improve the public health through learning and discovery. and added the words "and communication" to the mission statement of the school, which was voted upon and unanimously approved by our faculty. That's at a university, by the way, that has no journalism school. So that was quite a bold move at the time. And so it only is to say that we are in support of what you do. But I would ask here, what advice would you give professionals, physicians, public health people, academics, of how they can be better communicators from what you've learned at WebMD?
Yeah. I think many people just assume communication is easy. They'll talk to the patient, they'll talk to a colleague, and, everything is fine. And what we often don't acknowledge is that there are skills that we have to learn in communication. One of the challenges that we typically have in medicine and public health is that we speak at people instead of with them. We don't take the time to let them talk. We're not good listeners. That's an important part of communication. We often don't address culturally sensitive messaging. We don't address, interracial messaging. And we really, in many ways, just think there's a one size fits all. I'll just write something up, I'll just say it, and it'll work. And that's just not the way that it's practiced in real life. There are a skill set to communication. We have to learn how to do that. And we also have to acknowledge at times that physicians and other persons may not always be the best person to communicate. We've learned that in diabetes and created the field of diabetes educators because they're better at it than we are. So it is about learning the skills. One of the best aspects of leadership training is talking about communication skills and learning your style of communication and asking other people. We rarely do that, right, in real life. Did you understand my message? How did we do? Like even in medicine, I learned about the talk back technique where, I ask patients at the end of the visit, okay, so what did I tell you? What's the plan? And, a large number of times they don't remember what I said, or we use in health and medicine a parlance that doesn't make sense to other people. We don't even realize it. The other day, I said to my wife about something. I said, "Oh, that's malodorous," and she's like, "Malodorous?" She's like, "People don't use that word." I was like, "Yes, they do," and because I'm used to using that, in clinical practice. So I think it's about learning the skills, using techniques like talkback technique, making sure your messaging is culturally sensitive. And that's not something that we typically think about. And I think that will make a huge difference.
One of the problems in communications in health is an enormous overload of information. We've gone within a generation where people had very little access to the progress in health and medicine. And now they're besieged with advertisements for every known real and unreal condition on television and between halftime at Super Bowls. And at the same time besieged with stuff that is partially true or misinformation. How do you cope with that with respect to your presenting the best you can on what is true and not true and what is helpful and not?
Well, what I'm very proud that we do, and I wish more sites would do it, is every piece of content that is on our site is reviewed by a board certified expert. We put who that person is at the end, and we put the date that it was reviewed. So people can make some assessment about the timeliness of the information, as well as that it wasn't just something that we decided we were going to plop on the site because it was John's idea or someone else's idea. That there really has to be a process for content, a review process for content, a management system, and we don't see that enough. That's really the first step to help consumers get the best information. And then, Barry, I think we also have to work on giving consumer skills. How do you decide how to evaluate the information you read. In public health school and others, we really have that, how do we critically appraise the literature and have a process of how do we study a review article and dissect a review article? Well, how do we help consumers do that on information that they read online and in social media? And we often don't provide them the skills to do that. And I think we need to do more of that to help really separate the noise from what's real information.
One of the characteristics of medical science and all science is that it is constantly changing, and that the information that we are confident in or keen to share on any given time within 6 months may be very different. The issue of do masks work in COVID, for example, there just weren't data at one point. There are now data, and that led to issues of change in policy. So the first question that I put in that category is, how do you deal with advice that you've given or information that you've given that changes that may no longer be correct?
Yeah. And it's not just COVID. I could say it's the same issue about coffee. 1 year coffee is good for you. The next year it's not good for you. And then finally, lately, we've been hearing coffee is good for us in moderation.
And some of that came from the Harvard School of Public Health, I have to say, the good stuff.
So that's a good thing. I bet I could find conflicting information at some point. But the point is, there's uncertainty in medicine and in health. And people forget that most data are not black and white. It's gray, and it's subject to some interpretation. And we're always doing more studies. So in many ways, we are very quick in updating our content when it's clear that it is old or outdated. We are very good about putting the latest information, the latest studies online. And some of that then is optimized in search. So if you search information on the health benefits of coffee, on the benefits of mask, that will be at the top as opposed to an incorrect article or an outdated article. And then we have a general process, because remember, everything is dated, how we systematically review content on a certain time frame. And more people need to do that and recognize that. But part of it, Barry, is the role of search and how things are going to appear at the top of that list, so to speak, and giving the best information. My interest is, how is that going to happen when we have voice activated search, which is more and more? Alexa, what are the signs of multiple sclerosis? How do I know how they're using that information, and how do I know that's the best information? And there's not an opportunity to scroll and look around as many of us are used to. So that's going to be an interesting process in the future, the role of voice activated search in terms of making decision makings relating to our health.
That leads me to the question of who is your audience? What do you really know about your audience? And I'd be grateful to know, with this vast number of people who look at WebMD for 6 minutes, what do you know about them, and what do you learn from them?
Yeah, well, with nearly 80 million people to the site every month, it really reaches segments of everyone in society in the United States. But in general, the people that are the biggest consumers of information on WebMD are the same that are the biggest consumers of actual health in terms of the health system. So it's women. It's women who are a little bit older, and there tends to be 2 distributions: people in their 20s and their 30s, because they're searching issues of pregnancy, and then issues in their late 40s and 50s as people start to develop health conditions. It's people that skew a little towards more educated. So a high percentage of people that have graduated high school and some element of college, people that are more affluent, and people that are typically Caucasian. that's what it skews. I'll tell you, that's the same when I did health programming at Discovery and Discovery Health Channel. It skewed towards women, more educated, more affluent, Caucasian. They're the biggest utilizers of healthcare. So it's not surprising. But what's important is when you have a big denominator, either like at Discovery Channel or at WebMD, you're able to reach all segments of society. So it's important, as we talked about once, it's important to have those culturally appropriate messages, those culturally appropriate images as well, so you can continue to reach people. And obviously, most people come to WebMD to search signs and symptoms or treatment. They want to know about, should I be concerned if I have a cough? What if I have a headache? How do I manage, seasonal allergies? That's really popular right now. How do I tell the difference between that and COVID? So, in many ways, media platforms are very good at analytics. And we often don't acknowledge that in the research community, the public health community, but there's lots of information that we know about, what are people searching? And that can help guide us in terms of public health messaging. Because if I know a lot of people are asking about seasonal allergies versus COVID, that gives me good information. A lot of people are searching, does COVID vaccine cause infertility? Then I know I have to create more messaging around that.
I would ask you from the other constituency that you serve, and that is physicians. So I not infrequently hear complaints that patients walk into someone's office or clinic with a long list of things that they have diagnosed and the drugs they precisely wish to use to treat them. And that puts the physician in conflict with the advice they're getting. What is your experience with physicians and their responses?
Yeah, and I mentioned I see patients, and I do see patients. I don't tell them, I work at WebMD when they come in and they tell me they have a certain condition and need a certain medicine. But my approach is, and I would recommend to my colleagues, and I do hear it from my colleagues, although I'll be honest with you, not as much anymore, because sometimes the patients aren't coming in; they're just trying to manage their own condition. But I want them to come in. I saw a patient a few months ago who was sure he had sarcoidosis, and he basically had some back pain. And I had to say, that's not the typical symptom. You're not the typical race, gender, age. But it gave me a good prompt to understand why he thought he might have that, and what are his symptoms. So honestly, I don't get irritated by that. I think it's a great opportunity for discussion. And that's why I think I've been balanced by having worked in and out of the private sector and still being a clinician. So I'm using that as an opportunity to engage with patients, because it also says that patients want to have more control of their health. They want to manage their healthcare more. So how do we provide them the opportunity to do that in an effective way and still be part of that conversation? And in many ways, Barry, it shows this trend towards patient centricity. We've always focused on the physician. Let's keep the physician happy. Let's worry about physician parking, the physician lounge, the physician, cafeteria. We got to keep the doctors happy. And now we're starting to say, let's focus on the patient. Let's keep the patient happy. Why should the patient have to wait 20 to 30 minutes to see the doctor for a 10-minute appointment after, spending 45 minutes on public transportation each way? That doesn't make sense if we can do more care in the home. And this is where policy comes in. How do we have the right payment models? Let's be honest, telehealth worked because we had payment parity, because we paid the same amount for the visit. If we didn't, which we weren't doing pre-COVID, I'm not sure it would have taken off. But I don't get bothered as much by that. And I encourage my colleagues not to. It's an opportunity for discussion, because the patient is just searching for information. And maybe they're not the most skilled as I want to expect them to search the right terms, but it's an opportunity for discussion.
In that sense, this pandemic has been an opportunity that I would not have expected for the expansion of telemedicine. And could you comment a bit on your views of whether that will be retained when we all go back to work and some sense of normality, and how it will reach the underserved populations that are not easily able to get to hospitals, clinics, and doctors' offices?
Well, as many listeners may know, in January of 2020, before we really became aware of the pandemic, maybe we should have known before then, telemedicine visits represented about 2% of physician visits. By June of last year, when we were in the midst of full lockdown, it was 80% in general of patient visits. Now it's about 40 to 50%, depending upon specialty. I think telemedicine, is certainly here to stay. There are many things that I can manage over video and over the phone. And why should patients come in? I think we're going to have many more apps and other devices. So, a year ago, I wasn't necessarily able to do spirometry, right? I could do spirometry at home now. I could do pulse ox at home. I can give them, if they're, heart failure patients, certain other devices, remote patient monitoring to check on them. That's better for everyone. Why do patients, need to come in if I can provide the same level of care at home? Now, I can do cardiac rehab in many ways if they have the right devices, but there's still going to be needs for patients to come in. So I think it's going to be a balance. It's not going to be 80%. It's probably not going to be 50% in some specialties, but it's not going to be 2%. Will it be 20 to 30%? Will we figure out when is it most effective? Is it most effective for follow-up visits as opposed to initial visits? But I do have concerns, Barry, to your point, that instead of it perhaps being an equalizer in terms of reducing disparity, could it actually create more challenges and widen the gap? In some areas, what the number one telemedicine visit was around? Dermatology, right? So those are people in urban areas that had trouble getting appointments before, and telederm has, skyrocketed. Whereas in many ways, shouldn't we be using telemedicine to help those in rural areas reach specialists that they otherwise would not have been able to get an appointment with? But then how do we make sure they have the right tools? They have, the adequate internet service? How do we make sure we train them? There's only so much you can do on a phone, to be honest, in terms of a telemedicine visit. You can do more on a desktop or a laptop, with a good camera. We've learned that with schools, those students that are trying to use a phone to get their education, there's lots of challenges. So I think we have to be ready to address the disparity that persists in technology and not widen the gap instead of narrowing the gap, which really should be the goal of telemedicine. So I'm hopeful about that because I think people are starting to address it. But we have to acknowledge that and not just leave it for those that already are well insured, already, utilizing lots of services, and this is just a way to make their life more convenient. There's a role for that, but even more important, to be able to address disparity and provide access to people that otherwise might not have been able to get it, particularly because of geography, but also because of income as well.
The media and technology to get health out to at every possible level, the telemedicine is not such a new technology any longer. It's now being implemented. One of the new technologies is artificial intelligence, computer predictions of symptomatic or lab test integration. What is your sense is to that, the extent to which we can trust the algorithms that are coming out? To what extent will dermatologists be replaced by a photograph on a computer, or X-ray reading in my field of TB is now more accurate than radiologists by artificial intelligence? What's your sense of where that is going?
Well, here's the problem sometimes with dermatology, Barry. What are all the images of? Look in a textbook. It's the same thing online. It's Caucasians primarily. So how do we use machine learning? How do we use deep learning and AI technology to be able to accurately interpret a melanoma or other skin lesion, a seborrheic keratosis or dermatosis in a person of color versus Caucasian? So that's something that we need to address. The challenge that sometimes occurs with AI is the lack of transparency in the algorithm. So how do I know I can trust that algorithm? How do we protect intellectual property, yet at the same time, we need to have clinical adoption? This goes back to the point where I'm like, everyone is siloed. So the developers are on one side, right? AI developing it. And then sometimes they forget to talk to the actual clinicians that are going to be using the technology. So if we don't be transparent, if we also don't think about workflow, so how does that come into play? And then let's make sure we measure outcomes. Remember, we thought that AI was going to serve a great role in predicting the role of chemotherapy and which chemotherapeutic agents would be most effective versus oncologists. Well, as you know, that didn't prove out to be so good. It's going to be iterative, we'll see. But in radiology, the use of AI has done, much better in terms of being able to see trends or differences much more so than, our human eye. But we need to measure outcomes and we need to communicate that strategy. And as I said, be transparent about it.
One of the things that you've been very good on is indicating that as smart as we are, there is lots of uncertainty in what the data are, how well it's been collected, how good the algorithms are. People want certainty. When they come to WebMD with a set of symptoms, they would like to be able to know what the likelihood is that they have cancer or don't have cancer. And if they have cancer of this tissue, what the likelihood is they're going to get better. How does WebMD provide information that people can feel good about and confident about, and yet indicate the uncertainties in our knowledge and in the individual variation between individual patients?
And everyone likes to use the cancer example for WebMD. And everything people search does not, result in cancer. We have a very good AI-driven symptom checker, by the way. But, we don't give likelihood ratios like that. That would be interesting, wouldn't it? And we don't have all their medical information. And we're not designed, as I pointed out, to diagnose people's conditions based on what symptoms they put in. It's really meant to be a source of discussion. And if you put in information like cough or headache, really what in many ways we do is we offer you what could be some diseases that are associated with it, but also have some other symptoms as well. So we don't try to diagnose your symptoms all at once, just as I would if you came in to me without doing any additional tests. But what's exciting is, what's going to be that next iteration in terms of what information you might be able to provide? Could we recommend for you to talk to your doctor with either a telehealth visit or some additional testing? If you search certain signs and symptoms of sexually transmitted infections, depending upon where you live, we may be able to send you a link to be able to get STD testing, right? A lot of people don't want to come in and talk to the doctor about it. But if I could send you that link and you could go get it on your own, that could help. I might not be able to have that overall discussion with you about, safe sex practices, et cetera, but I'd also be trying to stem, sexually transmitted infections. So, I think one has to put it in the context of what sites are trying to do. They're really trying to provide consumers more information about certain health conditions. And then, giving what could be a range of diseases that you might want to talk to a health professional about. But then, Barry, it's also about if you came in, we have a huge diabetes content. You could come in and learn more about the diabetes journey. So you're already diagnosed. So we're going to talk to you about symptoms. We're going to tell you how other patients are managing their condition. We're going to talk about diabetes distress, the mental health aspects associated with a chronic condition. And then, separate fact from fiction, whether, it's reversible or not. I loved hearing about, the goal of eradicating cancer and having effective treatments that we've heard. But it's also about prevention too, right? We can't forget that. And we have to give people tips and tools around that?
That certainly resonates with former dean of a school of public health, where uh, so much of the concern is about treatment when
Yeah.
people are already ill.
Mhm.
When one looks at the predisposing conditions, for example, um, obesity as a precondition for heart disease and diabetes, um, that is so important to focus on. How do we prevent that? And that brings me to the question of, much of your audience, I would guess, are adults.
Mhm.
And yet prevention really works awfully well with children, well, vaccines being the classic
Mhm.
example. But do you have a focus within the framework of WebMD of, as you did in the Discovery Channel,
Mhm.
of how do you get things at a child's level of information that can be helpful and useful across the age gaps?
Yeah, absolutely. It's all about, health literacy and effective health communication. And despite the efforts of folks in government, they often don't do that well. I'll tell you, just having worked there, and that's where I feel people could balance more. But absolutely, we have a process in terms of making sure that we're communicating at a certain grade level, making sure that we're not using, as I referenced, the parlance of medicine and health professionals. But it also goes to the point, Barry, that different people like to learn different ways. So some people want to read text, other people want to watch video. I'll tell you, slideshows are still very effective. People like to scroll images and have smaller nuggets of content. Some people want to read it in the magazine when they're in the doctor's office. So it's really about understanding that different people like to learn different ways, and you have to provide the information in multiple ways to do that. And you also have to recognize no one can assume that once someone comes to the site that now's your chance to give them all the information because they're going to read it and study it and learn it. Sometimes it's about just one little nugget now, and then another nugget the next time they come, and then another nugget later, and get them interested in understanding and helping them understand the value of prevention. You mentioned about obesity. I often talk to patients, if you lost half a pound a month, just half a pound a month in 5 years, how many pounds will you have lost versus most other people will have gained weight? But nobody, wants to think that. They want to lose 20 pounds now instead of 25 pounds in 5 years, whereas other people would have gained weight. So it's a challenge, and we have to figure out more effective tools to do that. That's not gimmicky, because people still like gimmicks in healthcare.
As we come towards the end of our wonderful conversation today, I have to say that one of the major themes of the School of Public Health that I find such a privilege to be part of, and one of the commitments and concerns of every member of our faculty, staff, and students, is the issue of the disparities and inequalities in health. If you're wealthy in this country and well educated, you have access to so much knowledge that is available. And if you're not, it's a struggle. How does your leadership in WebMD and your vision for WebMD really come to grips with that fundamental problem, which would have such an enormous impact on overall improvement of health and equality in the United States?
Absolutely. It is a critically important point. And I think COVID has certainly taught us about the disparity that those that have worked in this space know has existed for decades. I mean, as Dr. King talked about, the greatest disparity is the disparity in health, and how prescient to have noted that, half a century ago. So, part of our effort is actually on the Medscape side, where we have created this health equity um, really panel and committee which is really going to help guide our programming in terms of education of physicians. So it's not just about, a separate lecture, but it's or educational tool, but it's also about embedding some of the issues that we know in terms of medical bias that exist in how we deliver care. So how do we help doctors, prescribers address some of those disparities to recognize their implicit bias? Because if you ask anyone, they're all going to say, oh, I don't treat patients differently based on sex or race or whatever, but we know they do based on data. And even when we've done virtual patients. So how do we not just create a separate equity center, and we've done that, but then how do we embed that content into general content about dyslipidemia, into general content in terms of management of diabetes and pre-diabetes? And then how do we make sure on the consumer side that we have representative images of the populations that we serve? So we have people of color, we have LGBT, we have these different images of consumers, of patients on our site. So when you search information, you will see people like you. And as I've talked to you before, I've worked with others to help raise awareness. It can't always be that the person of color is the patient and it's a Caucasian that's the doctor, or the male that's the doctor. We need to have these diversity of images on all websites when we talk about healthcare. But then we also need to embed the issues of inequity in our content and provide solutions to help address it. I've been talking about, we don't have to keep researching the issue, and to some degree you may disagree, of inequity. We know it exists. What we need to talk about are solutions of how do we address it, and then how do we measure it. That was something I was very interested in at FDA, where, how do we have, such small percentages of people of color in cardiovascular trials and diabetes trials? It's not hard to find them. So we're doing something wrong. We need to figure out how to improve upon it.
John, it's been an enormous pleasure. You are one of our distinguished alumni, and we're very proud of you and very pleased to have been able to have this conversation. We've learned a lot about you. We've learned a lot about a journey, an unusual journey to a position of leadership. We've learned about a lot about WebMD and communication and its responsibility to your audience, which is the American public. I hope you will be free to visit us in the not too distant future, in reality, not virtually. And to our audience today, please stay tuned to Voices in Leadership. It will resume in September. And we thank you for watching and wish you to be all very well.